Okay, let's try this one here to see if we have a different, can you turn around like so? Thank you. Okay, can we use your curve probe, the curve linear? Can we put it on a curve probe, C5 to 2? You have a MSK, yes, good. How deep is it? 8 cm, reduce that to 6 cm. Can you put it on 2 focus? Yeah, I know you can. Go next page. Okay. And then move the focus up down. I make them work really hard, you know, in their job. Okay, good. Okay, so we'll try and do the same transverse scan sequence in this young man here and see what we can see, okay? Right. Okay, so it's interesting. This is a little small package. Okay, you can see here, I'm going to show you the osseous anatomy first, okay? The first window. So you can see the spinous process, the lamina, and the posterior directed transverse process with the rib. If I now just slide the transducer slightly caudate, you get the second window. Can you see now? You can see the very nice thick intertransverse ligament with the pleura and the apical part of the paravertebral space. Actually, we are also seeing into the spinal canal here. So this is the spinal canal. So this is the lamina here. So if you do paramedian epidural, this is how the needle would go. So you can see this is the anterior complex, as we say. Now, I'm going to just slide the probe below the transverse process. You see here? Oh, can you see now? Okay. Can you reduce the depth? Now we can get a little bit better zoomed image. Reduce it. Okay, this is a little closer. Now, so this is the intertransverse ligament complex here behind it. So this would be the superior costotransverse, intertransverse, lateral costotransverse, and so on and so forth, with the levator costorum muscle here. This is the erector spinae muscle. Now, this is the inferior articular process. You can already see there are some hypoechoic spaces, which are the fat-filled, and this would be the retrolaminar space. I'm going to now pivot the probe. Pivoting the probe is a very simple maneuver. You just pivot the lateral end of the probe like so, okay? This is what we call the pivoting maneuver. So we are here. I'm going to scan transverse process, the level of the articular process here, and I'm going to pivot the probe laterally, see? I want you to focus on this structure here. If I don't pivot it, see, you sometimes don't see it so clearly. Can you see? When I pivot it, this is the superior costotransverse ligament here. Can you see? Now this large fat-filled space is the retro-SCTL space. This is the SCTL ligament here. This is the paravertebral space. And this is the connection that it has with the epidural space, etc. Can you freeze? Zoom in there. Can you zoom? Read zoom? No. No, not depth. Zoom. Just rotate the 2D, it will go zoom. No, not like that. Just rotate the 2D button. Can you? Okay, never mind. That's a homework for the application specialists. Okay, can you freeze it for me, please? Okay, so if you see here, what we are seeing is the spinous process, lamina, inferior articular process, the paraspinal muscle, erector spinae. Normally the transverse process would be here. This is the pleura. This is the internal intercostal membrane with the intertransverse ligament. And with the pivot, you can see the superior costotransverse ligament becomes very clear. This hypoechoic space that communicates with the ESP, erector spinae plane, with the retrolaminar space here, with the intervertebral canal and via I can't show you the lateral slit, okay? So if you can guide your needle behind the ligament and you place your needle not so close to this articular process, but behind it here, and you inject saline, you will see, like I showed you in the video, you will see spread over there. It seemed like a water is falling off the cliff sometimes. That's how I describe it. You will see when you inject saline, you'll see this gush of thing, and you see expansion of this space. So this is the basis of intertransverse process block and the retroacetl injection. So now I don't say that this should be your first line of attack for any thoracic cases. Like your paravertebral injections work very well. We don't know how these blocks work. They are technically very simple because you don't even need to identify whatever. But I showed you can identify a lot of these things. And if you can place your needle here and inject your local anesthetic, then some of this local will get into the thorax, into the epidural space, paravertebral space. And as I presented the data, yes, there is spread, but this is variable, inconsistent, and only a small fraction of the total injected. What we have also recently found in volunteers with this approach is that, yes, you get epidural spread on MRI, paravertebral spread, but the duration of sensory blockade is very short-lived. Within 2 hours, the blocks are worn out and they're ready to take the bus home. Okay? So this would not be a very effective block in terms of pain relief, but that is debatable because sometimes the somatic and sensory block effects wear out, but the sympathetic and effects on the dorsal root ganglia may live long on to provide you some analgesia. So we don't know all these things now, but I think it's becoming more evident with the growth of knowledge and experience in this area that the dorsal root ganglia may be an important player in this whole confusion or in this elusive mechanism that we often talk about. And you know these fibers, they are small diameter, they need low concentrations. And if any of you are pain physicians here, you can see that dorsal root ganglion injections require you to prepare for the injection long time. It's quite a complicated preparation. You cannot do it in the office. But this may be one way in which you can inject a very small volume of local or whatever, and the dorsal root ganglion just over there. So these are some new ways. This new anatomy is opening up new avenues for more targeted injections. Okay? So, thank you, sir. Okay? And thank you all. Okay, I'll leave it now.
Thank you very much. Thank you to Prof Karmakar and the rest of the faculty.